I wanted to say thank you to the organizers for organizing this event and for inviting me to speak here, and welcome everyone to World Health Day. It's great to have this event here at Tufts. As David said, I'll be speaking on the Haiti cholera outbreak, and I'm actually going to start in a place you might not expect. I'd like to start with Haiti's history. Haiti is, as we all may be aware, the western third of the island of Hispaniola in the Caribbean. So the other 2/3 of the island is the Dominican Republic, which we think of now as a tourist destination where we maybe go to a resort and we drink rum and we swim on the beach. Don't think we have the same impression of Haiti. And the difference is as to why the DR developed the way it did, and Haiti is in the space it is, I think has a lot to do with its history and how we react to the two countries. So the colonial history of Haiti, it was actually the first site that Columbus landed in the New World in 1492 on an island off the north coast. There was a local population, the Taino, who'd been living there. There was about 500,000 of them at the time that he landed. Within about 20 years, there were 50,000. That was due to exploitation for gold mining, as well as the importation of disease. Then, as the gold was worked out, about 850,000 slaves were imported from Africa into Haiti to work on sugarcane farming. At one point in time, Haiti made the most sugar of any country in the world. Those slaves revolted and took power back from the French in 1804. Haiti was actually the first black republic in the world and only the second free state after the United States in the Western Hemisphere. Now, that had its cost. France allowed Haiti to revolt with the agreement that Haiti would pay back France for the worth of every slave on the island. In 1804, that was $150 million was the worth of those slaves. They paid that debt off until 1922. So essentially, the money that was going in, the resources in Haiti, the wood, when it became deforested, the cane, was being sold, and that money was going to France through that time, not into the Haitian, to develop the Haitian economy. Now, as the Republic was established, there was a number of different leaders through 1915, and there was a lot of issues that went on that time. There was war back and forth with the Dominican Republic. There were power imbalances in Haiti. Those of mixed race actually had much more power than those who were fully African. Mulatto is the appropriate term in Haiti. I understand it's not the appropriate term here. But in Haiti, the mulattoes had much more power than those not. There was also a lot of kleptocracy. There was a lot of money moving back and forth, and the establishment of a lot of dictatorships. From 1915 to 34, the U.S. actually occupied Haiti, built a fair amount of infrastructure. Let's keep going. From 1934 to 56, there was a lot of different people in power, a lot of dictatorships, and then the Duvalier regime came in. The Duvalier regime bought political stability at the cost of essentially having a full dictatorship with a population that was a lot of violence in the population and a lot of fear. The Tonton Macoutes kind of ran the country in a way that there was a lot of missing persons. 1990s, after the Duvalier regime was overturned, Aristide's party came in, and Aristide was a Catholic priest. He grew up in poverty. He came in lavalas. It means cleansing flood. We're going to cleanse the politics of Haiti. We're going to bring this flood through, and we're going to establish a political party. He came in with a lot of hope in the 90s. There was a lot of hope in Haiti around this. Then in 1994, he was overturned by a military coup. The U.S. occupied again under Clinton. And then in the 2000s, we go back and forth between the military coup, Aristide being reinstated by the U.S., but then having only about a year left in his constitutionally mandated term. We see Preval elected, who was his vice president. We see another coup. And then in 2011, we see the election of Martelly. Martelly is a singer, a popular singer, who is now the president of Haiti. What I want to highlight from all this information is Haiti has never had a chance to develop a stable government for a variety of reasons that have to do with international issues around slavery. And then after, as we go through this history, we just don't have a stable government operating in Haiti. And as we look at what's happened in the context of these emergencies, we're looking at how to respond to these emergencies in the absence of this government. So the water and sanitation metrics, to be very honest, Haiti did better under the Duvalier regime than they're doing now. In 1990, about 59% of Haitians had improved drinking water, 47% had improved sanitation. Haiti's the only country in the world that has less improved sanitation in 2010 compared to 1990. Their improved water has increased a bit, but the water system has destabilized, and this was even before the earthquake. Okay. So January 12th, 2010, what's considered a pretty minor earthquake, 7.0 on the Richter scale, not that big, led to about 300,000 fatalities and 3 million affected. This has a laser pointer. Here, in this kind of part of Haiti, is Port-au-Prince. Here, 17 kilometers away, is the epicenter of the earthquake. This corridor here is kind of the heart of Haiti's population density. There's a road here that goes out this direction. There's also a national road that comes up here towards St. Mark. So in this area of the most affected, there's about 3 million people. The earthquake hit right at the population center, and the reason there were so many fatalities is Haiti has has super poor quality construction materials. The concrete and the rebar that form the majority of the buildings on the island are poor quality, and they just crumbled. And then when the concrete and rebar crumbled, that construction material cannot be reused as new construction material. It's not like you were in an earthquake in Indonesia, your brick house fell down, you take your bricks and you make a new house out of those bricks. That material was waste. So not only did it all crumble, but then you had to move the rubble. And moving that rubble out of Port-au-Prince, 2 years later, people were still moving it. There was extensive internal displacement. People moved both into spontaneous settlements within the Port-au-Prince area and also moved out into rural areas. People sent their family away, but that strained resources within rural areas. I happened, at the time that the Haiti earthquake happened, to be working on my PhD at the London School of Hygiene and Tropical Medicine. And my PhD was supported by UNICEF and Oxfam to answer the following questions. What role, if any, should point-of-use water treatment, household water treatment, play in emergency response? And what are the factors associated with feasible and potentially sustained implementation of point-of-use water treatment in response to emergencies? Now, I had something I'd never recommend for a PhD. I had an open protocol. I was supposed to go to 4 emergencies that were going to happen during a year and just respond to what point-of-use water treatment options were distributed by responding organizations. So I had my calendar, and I had, every quarter in the year there'd be an emergency, and I'd go and I'd come back and I'd analyze the data, and the next quarter I'd repeat. Of course, it was the driest emergency year on record, and I come to August and nothing's happened. So I go in August, October, January, and February, which wasn't the plan. But Haiti was actually the last of these that I went to. I responded. I was in Haiti 3 weeks to 8 weeks after the onset of the emergency, of the earthquake, looking at water treatment interventions that had been distributed. So my research plan, I did information gathering, who distributed what water treatment where. I did spatial analysis. Where did those people receive it? I did GIS analysis. We've actually continued that research with some Tufts undergraduates here. I did household surveys at 400 households that had received products. We did water quality testing, both microbiological testing and free chlorine residual testing. This is one of my enumerators, testing free chlorine residual at the household level. We did qualitative interviews with responders and recipients, and we did a cost and logistics analysis. So it was a full mixed methods analysis to look at how the interventions worked. So I'll do just a couple slides on this to give a sense of the complicatedness of you don't just hand something out in emergency and assume that it's going to work. What makes it work? What makes it not work? So in terms of the coverage, we found that in the first 8 weeks after the earthquake, 4,618 families were reached with household water treatment options. About 3,000 were reached with this bucket with a lid and a tap, a safe storage container accompanied by aquatabs, a chlorine tablet. Aquatabs were also given out in some spontaneous settlements. There were about 350 ceramic filters distributed. There were about 238 biosand filters distributed, and there was about 70 bottles of powdered chlorine distributed, chlorophyceal. Now that sounds kind of nice, about 4,500 families, until you realize that's 0.77% of the affected population, and in the same time period, 900,000 people were reached with the intervention of tanker truck water. So it's actually a quite small slice of the pie. The results, I have tons of results. I'm just going to keep it here because I want to highlight this one point. Our main outcome metric for the study was, did the house improve the quality of their stored household water from dirty, contaminated, to meeting World Health Organization standards, clean, using the intervention that was given to them. So they had to have dirty water, they had to use the intervention correctly in order to make clean water, right? So that was our outcome metric. We called it effective use. And what we saw was a huge range in effective use. We saw the aqua tabs that were given out with this bucket by the organization Deep Springs International had the highest effective use. Over half to 2/3 of the population in urban and rural areas effectively used the option. They were given community health worker weekly trainings. They were given a safe storage container. It was an NGO that had operated in Haiti before, so they had training materials in Creole. They knew what they were doing, right? Okay. The same option, aqua tabs, the chlorine tablet, given out by Haiti Response Coalition in the spontaneous settlements, much lower effective use. There was no training. They were simply a handout. Here's some aqua tabs. Take them to treat your water. No training materials, no follow-up in Creole. Chlorophyll was quite low use. Again, the same situation. No training, no follow-up. And the ceramic and biosand filters were slightly more complicated. The ceramic filters were handed out with training, but they were the way the ceramic filters were handed out, they were flown in from the Dominican Republic, and they landed at, we found a lot of airstrips in Haiti after the earthquake. The airstrips were, everyone knew what an airstrip was. I had no idea. They were all drug smuggling airstrips. So we knew how to land planes, small planes from the DR in Haiti to get supplies in. But so they took the small plane, they landed it on a drug smuggling airstrip in Jacmel, and they handed out ceramic filters to the people around the airstrip. Well, they didn't ask these people if what water supply. They actually had perfectly clean water coming to them. These people didn't need the filters, right? Biosand filters were a different thing. They were handed out, but everyone in Haiti was affected. 300,000 people died. Everyone knew people who died. The technicians that installed the biosand filters in the time right after the earthquake were a little affected, and they just messed up their job. They installed the biosand filters incorrectly so that they didn't work. So we have a product that doesn't work, installed incorrectly, so not actually treating the water. So when we come to this, we found 3 things were necessary for effective use. A water treatment option that worked, people actually having poor water quality, not having clean water, and context. You had to have people who knew the option before the emergency, NGOs who knew Creole and could give out the appropriate training materials. And when these 3 things came together, what we saw was effective use of the point-of-use water treatment products. So it's more complicated than just handing something out. It's about how does it fit into the local culture to encourage people to use them correctly. Okay, so let's move on to cholera. CDC on March 2nd, 2010, when they published what public health professionals should be prepared for in Haiti in the post-earthquake context, posted on the internet, cholera is extremely unlikely to occur. Cholera was not known in Haiti. They assumed that any responding organizations that would have people come in who are potentially affected would have adequate treatment of their feces so it wouldn't come into the environment. And they published this. And so people were not preparing. We were preparing for other outbreaks. We were preparing for typhoid. We were preparing for malaria. We were preparing for dengue. But we weren't preparing for cholera. So cholera did come back to Haiti. The first case was confirmed by the Ministry of Public Health and Sanitation on October 22nd, 2012. It was the first case. It was the first confirmed case ever in Haiti, but it was the first symptomatic case in over 100 years. To date, the outbreak is ongoing and endemic and has claimed over 8,000 lives and over 700,000 people. About 10% of Haiti's population has been symptomatically infected with cholera. And there were multiple theories of arrival. Dean Abriola talked about this. People said it arrived in Haiti from changes after the earthquake. The geology of Haiti changed after the earthquake, the water quality, the temperature. And so it came in from the Gulf of Mexico. There's ambient strains in the Gulf of Mexico, and maybe it came in after the earthquake somehow. Cholera is a very rapidly evolving and changing bacteria. So maybe it evolved over, there was some natural evolvement of background cholera in Haiti that led to it being a toxigenic disease-causing cholera instead of a non-disease-causing cholera. And the third theory was that it was introduced. Someone came with cholera, their feces got in the environment, and it was introduced into Haiti by a specific person. Now, the widely held belief in Haiti was that it was introduced by MINUSTA, that's the French acronym for the UN peacekeeping mission. It was introduced by a MINUSTA soldier from Nepal at a specific facility in Meye. And that's what the Haitians believed. So an independent panel to investigate the source of cholera was commissioned by the Secretary General of the United States in December of 2010, 2 months after the outbreak started. The mandate was to investigate and seek to determine the source of the 2010 cholera outbreak in Haiti. And we did mixed methods research. We looked at the epidemiology of the outbreak with an epidemiologist. We looked at the water and sanitation piece of the outbreak, myself as an engineer. And we looked at the molecular data to see what the cholera, that actual particular cholera in Haiti, what that cholera looked like when you compared it to other cholera strains across the world. So we were in Haiti in February, 4 months after the outbreak. And we were looking at retrospective. What information could we gain retrospectively? For various reasons, none of the organizations on the ground in October chose to investigate the source of cholera. They deliberately decided not to look into it. So we were looking retrospectively 4 months later. One of the things we did is actually visit sites along the Artibonite River. So the Artibonite River, let me just go back 1 sec. This is the area of Haiti where the earthquake was, down here around Port-au-Prince. The cholera actually started up here in Sainte Department at the, along the Artibonite River, and the main cases all happened here. This is outside the affected area of the earthquake. So when we come back, now this map is the Artibonite River. This is the Google Maps. Up here is the headwaters of the Artibonite, and this is where the Meye-MINUSTA facility is. And so these are some of the headwater streams, and then they come together and join into the Artibonite here. The facilities down here, their septic waste is across the road, actually. And so, and then you follow the river, and there's a road that goes down the river, and there's a number of hospitals, and then you come out down here into the ocean. So, of course, our first big question is, did the cholera move from here to here, indicating that it might have come in from the Gulf of Mexico, or did the cholera move from here to here, indicating that the outbreak started up in the mountains? So what we did is we went back direct to the hospital records in Haiti. And when you're admitted into a hospital in Haiti, there's a book, and it has lines, and it's like, Daniele Lantagne was admitted because she went into labor on July 15th, 2012. She stayed for 2 days, and then she left with a healthy baby. And that would be one line, and that's all the information that you have about that hospital admission. Right? And so what we'd have is, you know, this person came in with diarrhea, et cetera. This person came in. What we looked at was the background rate of diarrhea, and then when we saw the spike, when we saw that there was all of a sudden a lot of diarrhea cases coming to the hospital. We saw that spike on October 20th here at the hospital in Meye. We saw it on October 21st here at the hospital at Albert Schweitzer, and we saw it on October 22nd here at the hospital of Hôpital St. Nicolas. Here at the hospital in St. Nicolas, we saw 404 cases in 24 hours, which meant one cholera case came in every 6 minutes. And the hospital thought God had come down and was destroying Haiti because they'd never seen cholera before. Cholera, you can lose up to 20 liters of fluid from your body a day. They had no idea what was going on. So we ascertained the outbreak started here and came down. Okay, the second thing, water and sanitation. This river is controlled at the Pathogenic Dam, and so the Pathogenic Dam provides hydroelectric power down to Port-au-Prince. So we know that they release water from this dam and it comes down, and then here's canals. And it's also controlled at a dam here, and then it goes out. This is all agriculture. And so this canal puts it into agriculture canals. So I thought there might be stuff I could do engineering-wise, that there would be river flow data, that they would have cross-sections and transects, and I could do a model. Actually, when they release water here, this guy calls this guy on his cell phone, and they know the water comes in a day. And they know the water goes from here to here in a day, which actually matches the epidemiology. It's not hardcore engineering, but it matched. Lastly, we looked at the molecular data, and the molecular data showed we didn't have the Nepal strain sequenced at this time. The molecular data showed that the strain was closest to South Asian strains. This is just an image of the disposal. This actually meets UN current regulations for disposal of soldiers' feces from peacekeeping mission sites. It's an open pit with their feces. So our conclusions at the time we wrote the report was these research findings indicate that the 2010 Haiti cholera outbreak was caused by bacteria introduced into Haiti as a result of human activity, more specifically by the contamination of the Meye Tributary System of the Artibonite River with a pathogenic strain of the current South Asian type cholera. Now, as you can see in that, we didn't blame a specific person, and received a lot of criticism for that we didn't blame. We kept to the science that we could ascertain retrospectively. This is what we knew. Now, there's been additional research on the epidemiology. The Nepal strain has been sequenced. The Haiti strain is an exact match to the Nepal strain. And Partners in Health has done additional work to find cases in the community that died before they made it to the hospital. All of that data coming together supports our evidence, strengthens it. And so what we can say now in 2013 is the most likely source of introduction of cholera into Haiti was someone associated with the Mirabole facility. We couldn't say that with the data we had in February of 2011. There's a lot of stuff going on right now, the call for the removal of MINUSTA from Haiti, and then talking about vaccination campaigns. A $2.2 billion cholera elimination plan for the island of Hispaniola was recently released. It's funded, $200 million of it's funded, so there's a question of whether it's an unfunded mandate and how much it would have. Couple slides on the government of Haiti, coming back to this. DINEPA is the state government structure for water and sanitation. It was established in 2009. It's 3 years old. Its role is to execute the government guidelines in the water and sanitation sector, and its key interventions are to develop the sector, regulate the sector, and monitor the sector. There's a lot of need for regulation of water and sanitation in Haiti. Clearly, after the earthquake and cholera, the immediate response was massive distribution of products, point-of-use water treatment products to Haitians. This is a woman who was given a life straw filter and a bottle of chlorine. Neither are opened. Neither of them is she using. A lot of new programs were implemented by NGOs trying to help, trying to do good, but there's no coordination, there's a lot of duplication, there's a need for sustainable projects, there's a need for regulation, and there's a need for a coherent government response. So what we've done is we've worked with the Haitian government to do strengthening of the Haitian government system to develop some national strategies around water and sanitation. We launched the program, this was when I was working at CDC and has continued now that I'm working at Tufts with a number of organizations. We've led some trainings of government staff and NGO partners. We've developed norms, political norms, guidance, political regulation around water treatment in Haiti. We've done evaluations. We've developed a national strategy for water treatment in Haiti. And we've worked in partnership with other ministries, Ministry of Health, Ministry of Public Health and Sanitation, Ministry of Environment, and we also have done some pilot projects to the government becoming actively involved within regulating the water treatment sector in Haiti. So what now? Currently Haiti is post-earthquake, is still not fully recovered, is post-hurricane. There's hurricanes I was in Haiti in November 2011. It was 11 months after the earthquake, 1 month after cholera. I was there in a hurricane and there was political violence around Martelli's election. And I told my enumerators that the next day we weren't going to sample because they had the day off because the hurricane was coming. One of my enumerators turned to me and she just said flat out, God hates Haitians. And I think this is a country we have to understand the current system of how many emergencies are heaping on top of it. None of this is changing quickly, and how do we work in this complex emergency context? And there's a lot of desire to help, and there's a lot of people who try and help Haiti. And how do we do that? And that's a difficult question with no easy answers. And I think some thoughts I've come to after 13 years of working in Haiti at a lot of different levels. We need to strengthen the government. We need to address kind of the core issues. Well, household water treatment is a Band-Aid solution. We also need water and sanitation infrastructure. We need to work on both. We need to coordinate with other actors so we don't replicate. We need to complete ethical research programs. We need to work toward political stability and building resiliency if possible in Haiti. And we need to understand the complexity. Things aren't going to change fast. Money that goes there, there's going to be questions about where it goes. And so as a Haiti cholera Watsan expert, what do I recommend? I mean, people have asked, is it better to do nothing? I don't think it's better to do nothing. I think we need to do work. But these are incremental improvements, and we need to gather the evidence to make those improvements successful. And that involves engineering, and that involves the social sciences, and that involves a lot of interdisciplinary collaborative research of the type that Tufts University can do. I just want to end with a positive. This is a woman in a spontaneous settlement in Port-au-Prince a month after the earthquake. She has treated water that is microbiologically clean for her family, and she is breastfeeding her infant. This is what we want to support. We want to make it easy for mothers to take care of their families. And I want to end with this quote: "The notion that being humanitarian and doing good are somehow inevitably the same is a hard one to shake off." I think a lot of times being humanitarian actually does not the good we expect, and that researchers and academics can help align being humanitarian with doing good by promoting evidence-based interventions. Thank you so much for having me here today, I'm happy. Is there time for questions, or are we moving on? No questions. Okay, we're only 3 minutes behind. Okay, we're skipping questions. Thank you so much for having me.